Make sure that the provider databases contain all the basic provider information that is needed to support their inclusion or exclusion in the program, and then use this information to develop verification procedures. And finally, keep current with new technologies and services that support closer and more frequent review of providers, and consider whether investing in these technologies will be cost-effective for your plan. Another thing we encourage plans to do is to make use of state and national databases. These may help them maintain the integrity of their provider relationships. In addition to the federal and state OIG exclusion lists, other databases of excluded providers also include state licensing files, NPI records, and Drug Enforcement Administration numbers. Providers that lack these credentials are ineligible to receive federal health care payments. Not that long ago, it was impossible for a plan to regularly access all of these databases to check on the status of every provider. But thanks to advances in technology, tools are now available to help plans access this data and frequently verify a provider's status, in some cases in real time, before paying a claim. Another important point is that it's up to each plan to obtain the results of reviews conducted at both the state and the federal levels, and these may document excluded providers as well. The third area plans will need to consider is their own fraud and abuse safeguards. CMS's Medicaid Integrity Group, or MIG, which was established in 2007, conducts annual comprehensive program integrity reviews of 1/3 of states. These reviews enable CMS to determine the extent to which Medicaid programs comply with federal program integrity standards. They also help CMS identify program vulnerabilities and effective practices. Historically, MIG has identified Medicaid managed care as the area most vulnerable to program integrity issues. Their report states that MCOs often fail to verify receipt of services through an explanation of benefits or other method. They also found that states don't track MCO fraud and abuse systematically. Finally, the report indicates that states simply don't provide enough oversight of the integrity of their MCOs. Although CMS hasn't yet issued specific guidelines on this matter, the Inspector General will nevertheless proceed with its review to determine whether plans have developed adequate internal administrative and management procedures to guard against fraud, waste, and abuse and are sticking to them, and also the extent to which states are overseeing plan compliance. Overpayments are another particularly sensitive subject for states. States take issue with MCOs for their failure to report recoveries of overpayments in any meaningful way. Many states believe that plans aren't incentivized to report overpayments because doing so could negatively impact future rate-setting processes. Or in other words, if a plan reports X dollars in overpayments, that amount will be factored into their per member per month capitation payment, and a corresponding rate adjustment would be made. MCOs should continue to follow their own procedures for fighting fraud, waste, and abuse. Claims editing and other processing safeguards are valuable program integrity tools, and special investigative units can also effectively identify and investigate areas prone to fraud, waste, and abuse. Additionally, if plans aren't doing so already, we encourage them to work on strengthening their controls to make sure that they meet the 6 rights of program integrity: the right care, in the right amount, for the right patient, at the right time, in the right setting, and with the right payment. Remember, these evaluations must identify and address MCO-related concerns expressed both by the MIG and the ACA. At a minimum, plans should be evaluating and addressing the areas focused on by their state's Recovery Audit Contractor Solution to make sure current policies and procedures are in alignment. Plans also need to assess their vulnerability and put processes in place to address areas specified by the MIG, including making sure that services paid for were actually provided. Finally, plans must be prepared either to provide the states with more robust overpayment information or to be subject to even more state-level reviews at the encounter level. The fourth area of the 2011 review is prepayment reviews to detect and deter fraud and abuse. With the advent of new prepayment review requirements for state agencies, MCOs must pay significant attention. An effective way for MCOs to prepare for the upcoming OIG review is to develop a comprehensive prepayment review system. A system that includes predictive modeling for scoring claims can be significantly more effective than the traditional post-pay, pay-and-chase methods. Effective prepay review systems might also include rules-based screens and edits with NCCI, do-not-pay lists, and other safeguards in place. So plans should consider these three things. First, rules-based editing that includes the specific areas outlined in the Affordable Care Act. Effective October of 2010, Medicaid agencies are required to incorporate NCCI methodologies into their claims payment systems to control improper coding and prevent inappropriate payment. Second, regarding do-not-pay lists, a June 2010 presidential memorandum directed state agencies to check certain databases before making payments to be sure that Medicaid funds don't go to dead or excluded individuals. Currently, states don't have access to all the necessary databases, and your plans may not either. Nevertheless, this mandate underscores the level of effort that's expected from states and MCOs to eliminate improper payments. And third, the predictive modeling approach supplements the simple logic of rules-based screening and editing methods with a more powerful technique for detecting claims with a high probability of payment error. The predictive model looks for fraudulent patterns across claims by considering a number of factors that are too subtle and complex for traditional rules-based screens and edits to identify. As claims enter the adjudication system and pass through traditional prepay screens and edits, each claim is scored for its risk of improper payment. The score is based on proven relationships between claim characteristics, provider characteristics, and overpayment risk. Claims with relatively high scores would be most at risk of being overpaid if paid outright. To ensure that MCOs are doing everything they can to meet federal mandates to reduce inappropriate spending, the Inspector General will review how Medicaid MCOs are using prepayment reviews to detect and deter fraud and abuse. Reviews will likely identify vulnerabilities and will result in recommendations for future action, since there aren't any clear compliance requirements at this time. However, plans can help themselves from both a compliance and a financial perspective by investigating and evaluating these technologies. And plans should consider incorporating expanded reviews as part of their approach for creating a comprehensive program integrity solution that addresses the 6 rights. It's a good idea for MCOs to develop a comprehensive prepayment vision that incorporates the following functions: prospective identification of recovery audit findings, NCCI and other prepayment edits, upfront coordination of benefits and cost avoiding for other insurance, and continual reconciliation of payment methodologies and reimbursement changes with claims payment modules. The last point we'll discuss is duplicate payments and capitation payment errors. Often, multiple payments are made to providers for individuals with more than one Medicaid number. This practice regularly wastes millions of dollars. To prevent improper spending, the OIG will now treat all concurrent fee-for-service and capitation payments as duplicate payments, even if they're paid for different Medicaid numbers. An example of this is a state paying a provider on a fee-for-service basis while also paying capitation rates. The state considers this a duplicate payment since it's paid both the capitation rate for the time period and also the claims for the beneficiary. Here's another example of a duplicate payment: fee-for-service payments for family planning services received by the beneficiary from a provider outside of the MCO network. In this case, state agencies would be permitted to bill the plan for the cost of the claim. Duplicate payments may also result from overlapping inpatient claims paid on a fee-for-service basis by the state and also by the MCO to the provider. The most frequently occurring capitation errors are: 1, when beneficiaries are institutionalized and receiving other coverage, and 2, when a beneficiary's death hasn't been recorded. To prevent these payment errors, the Inspector General will begin identifying beneficiaries who live in these facilities and then review capitation payments to see if the state paid the plans while the person was institutionalized. The OIG will also review costs reported for beneficiaries living in long-term care facilities to determine whether the capitation rates are appropriate. The Inspector General will also review and counter data associated with supplemental capitation payments to ensure its accuracy. This type of data details services provided by an MCO to a member and is reported to states for their records. Frequently, this data relates to the addition of a newborn to the plan. It's wise for plans to consider partnering with state agencies to locate the source of duplicate payments, identify and recover incorrect payments, and come up with a plan to prevent future payment overlaps. The best approach for plans is to regularly meet with states to understand and review any findings in these areas. Another recommendation is for plans to begin matching for deceased beneficiaries and recovering any claims paid after date of death, if they aren't already doing this. Once the funds have been recovered, plans may then choose to share updated beneficiary information with their states. Plans may also partner with states to ensure correct enrollment data. Here are some suggestions for how to partner with states, recommendations for individual action, and a look forward at what plans can do to prepare for what's coming. We believe that you should take the following steps. Evaluate a method for identifying provider exclusions. Analyze and review your credentialing approach to make sure it meets review requirements. Determine that robust editing is in place for NCCI within your claims payment system. Work to expand your prepayment review efforts and adopt mandatory provider compliance programs, including provider self-reporting in your contracting process. To get ready for the upcoming review and avoid any negative impact,